So please join me now to introduce Dr. Jacqueline Bhabha, who and the keynote panel. Jacqueline, Dr. Bhabha is a professor of the practice of health and human rights at the Harvard T. Chan School of Public Health and the Jeremiah Smith Jr. Lecturer in Law at Harvard Law School and an adjunct lecturer in public policy at the Harvard Kennedy School. She is also the Director of Research at the FXB Center for Health and Human Rights here at Harvard. Please welcome me in welcoming Dr. Jacqueline Bhabha on the panel.
Hello, everybody. Welcome to our conference and happy Roma Day for all the Roma friends and colleagues in the room. Along with Dr. Matake, I think I am the only person who has been at all of our Roma conferences. This is the 11th one. And so I thought I would abuse my position as chair of the next panel by just reflecting very briefly on what these Roma conferences mean to me, to Magda, and to our center. We see them really every year as a time of reckoning, of different types of reckonings. Initially, I think our very first agenda was to reckon with the radical ignorance amongst US scholars, activists, anti-racists, political scientists about who Roma were. When we said that we were inviting people to a Roma conference, we had to explain what we meant and why we were including Roma issues in the agenda of a university center dedicated to working on health and human rights issues. And our initial goal was quite modest, but at the same time ambitious, because not only did we want to explain to our colleagues and our comrades in the US why Roma issues are important, we also wanted to insert attention to Roma issues in the academic agenda of social scientists working on racism and on different manifestations of social injustice. So that, I think, was quite an ambitious agenda. Moving on, our conference has also presented us with an opportunity for reckoning with some of the gross distortions embedded in what is often called social science. In the case of Roma, and this is an issue we encountered very early on, there was the often repeated truism that Roma children were deprived of education because their parents were not interested in sending them to school, either because they didn't value education or because they valued more the economic benefits of making their children beg or steal. So when we started our work on Roma-related issues, our first target was education. And our first target within that was to reverse the lens from the alleged faults of the Roma community to the faults of the education systems into which they did not fit. And so our early studies showed how dramatically traumatic schooling is for so many Roma children in Europe. Exposure to bullying, exposure to discrimination, exposure to racism in the classroom by teachers, exposure to all sorts of unconscionable behaviors, which maybe some of the panelists who will follow me will talk about. But we've also more recently had a more local reckoning, a reckoning with the widely celebrated hospitality of the United States as a country of and for immigrants, a country where we thought, unlike Europe, Roma who've come here over the decades are included, sheltered from discrimination, given unprecedented opportunities. And so we started researching the situation of Roma in North America, starting with this country. And at research that we presented at one of our recent conferences, and I think maybe others will talk about this, we showed how wrong we were in having the hypothesis that the US would be a more hospitable terrain than Europe. how wrong we were to think that we would make a contrast between the racism of Europe and the inclusion of the US, because our evidence showed quite clearly that Roma communities in the US are also exposed to many of the same behaviors that their peers in Europe experience. And our report, which for those of you who haven't read it and are interested is available, our report documents that in considerable detail. And so to our reckoning today. Just as we looked at health, at questions of education and questions of exclusion from academic research, so today, fittingly, in Harvard Medical School, we are looking at health and ill health. And what we are focused on, again, is reversing the lens away from the unhealthy habits of particular populations to the unhealthy treatment by health-related institutions. And others have already spoken, the Special Rapporteur spoke very eloquently about risk factors in health and ill health. And our panels today are going to look at this in more detail. And I am really delighted that I think for the first time we've moved the seat of this conference from the other side of the campus to this medical health related part of the university, because no more important issue could really take place in this building than to think about these collective problems together. So I'm delighted that our keynote panel will address this claim head on, and I'm honored and really excited for all of you who haven't heard my colleague, Professor David Williams, talk. He is, and I won't go into his bio because we all have it, a leading authority on racism as a risk factor. He's done decades of work. He's really a signpost in the field. And I think many of us here have learnt from his research, from the strategies he's used, from the body of work that he has assembled and overseen. And so, Professor Williams, we're extraordinarily thankful that you decided to join us today. Thank you for being with us.
Thank you so very much, and it's truly a pleasure to join you today. And I'm grateful to have Magda as a faculty colleague in my department, and I was happy to accept the invitation from her to put in a global context the issues of racial inequalities in health and racism. So I'm going to run through my slides since I have a lot of them. But to give you a quick overview of the challenges we face when we deal with the issues of race and racism in a global context. So first of all, there are large inequities in health around the world. I begin with infant mortality in the United States, where we can see that Blacks and Native Hawaiians and American Indians and Hispanics all have higher rates of infant mortality than whites do. If we go to data on England and Wales, we see Pakistani, Blacks from Africa, Bangladeshi, Black Caribbean, and Indians all have higher rates of infant mortality than whites in the UK. If we go to South Africa, we see the patterns of infant mortality mirror the legalized apartheid of South Africa society, where there was a ranking of racial groups, where Blacks are doing better than coloreds, who are doing worse than Asians, and Asians doing worse than whites. And that was the framing there. If we look at Latin America, we can see, comparing the Afro-descended population in various countries of Latin America to the non-Afro-descended populations, you see higher rates of infant mortality, again, across Costa Rica, Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia. You see a consistent pattern. If we now look for the indigenous population in Latin America, you see higher rates of infant mortality in Costa Rica, Uruguay, Mexico, Colombia, Brazil, Venezuela, Peru, Ecuador, Panama, Guatemala. So it's a global pattern everywhere we look. If we look at life expectancy for indigenous men, looking at the Maori in New Zealand, Aboriginals in Australia, First Nations in Canada, and American Indians in the United States, you could see a 7-year gap in life expectancy, lower life expectancy for the indigenous in New Zealand, Canada, and United States, with the gap being 3 times larger in Australia. And race ethnicity is related to socioeconomic status, income, education, occupational status, and wealth. To illustrate that, I'll use US data, median household income, and I'm presenting it in a way you can't miss the point, standardizing on the household income of white households as $1. You can see that Asian households have $1.23. Asian households are more likely to be multi-generational, so there are more persons contributing to household income. If we had a per capita measure of income, whites would have the highest. But if you look at the historically disadvantaged groups, for every dollar of household income white households earned in 2018, Hispanic households earned 73 cents, and Black and American Indian households earned 59 cents. What is stunning about the 59 cents figure for Blacks in 2018 is that it's identical to the Black-white gap in income in 1978. 1978 was the peak year of the narrowing of the Black-white gap in income as a result of the civil rights policies of the 60s and 70s and the war on poverty of the 60s and 70s. So it was narrowed to 59 cents. And today it is still 59 cents. Has it been stuck at 59 cents? No, it got worse throughout the decade of the 1980s. Reaganomics was not good to the Black community, and it was not until the mid-1990s, in the middle of the Clinton administration, it got back up to 59 cents, and it's a penny up or down from that since then. The key point is we've made a lot less progress than most people think. And again, we see the same pattern elsewhere. You can see for every rand, the South African currency of income, that whites earned, Indians earned 60 cents, colors earned 40 cents, Blacks earned 20 cents. That is progress. In 2015, under apartheid, Blacks earned 10 cents for every rand that whites earned, but you can see how large the gaps are that persist. And just to illustrate, the pattern is universal. If we look at child poverty rates by race and ethnicity in different Latin American countries, you can see that both the indigenous population and the Afro-descended population have higher rates of infant mortality in every country where we have data. So again, it's a global pattern. We see that pattern everywhere. And large racial gaps in income dramatically understate the racial gap in economic status, because income captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. And if you look at the US data from the Federal Reserve Board, for every dollar of wealth that white households have, Black households have 10 cents and Latino households have 12 cents. And again, to illustrate that this is a global pattern, I have data on wealth by ethnic group in the United Kingdom. For every pound of wealth that whites have, Indians have 95p, Pakistanis 50p, Blacks from the Caribbean 20, and Blacks from Africa and Bangladeshi 10. So again, striking inequities across various contexts of racial status, predicting access to economic resources. When my career started, most researchers thought that racial ethnic differences in health were simply a function of differences in income and education. And if you looked, for example, Blacks and whites at the same levels of income and education, race would no longer matter. We now know that life is more complicated than that. I'll illustrate that with 2 examples. Infant mortality by mother's education, less than high school completion. You see there's a racial gaps there with Blacks and American Indians having particularly markedly elevated rates. This is among those who have completed high school, those with some college, those who have a college degree or more education. So you see race continues to matter at every level of socioeconomic status, in this case, looking at data on mother's education. Just to pick another example, here is data from Brazil. And again, you can see that the Black and the mulatto population have higher rates of infant mortality at every level of mother's education. So there's something else about race that matters even after we've taken income and education into account. And so I and other researchers for the last quarter century have been asking the question, could racism be a critical missing piece of the puzzle to understand the patterning of racial inequities in health? In 1967, activist Stokely Carmichael and political scientist Charles Hamilton coined the term institutional racism in the book they wrote entitled Black Power to capture dimensions of racism that were built into laws, practices, and the culture of societies and of institutions. In 1972, James Jones, African-American social psychologist, wrote an influential book where he identified 3 aspects of racism, what he called personally mediated, internalized, and institutionalized. Importantly, both Jones and Kwame Ture is what Stokely Carmichael changed his name to, and Charles Hamilton used the language of institutional racism, and I did in my early work, and you see it in Kamara Jones's Gardener's Tale as well, in a way that researchers today, as Joe Fagan points out, now use the term structural racism and systemic racism to what was originally called institutional racism, included what today is called structural and institutional. So let me talk about the ways in which racism plays out, heavily emphasizing US data just to illustrate the phenomenon. I'll talk about the house that racism built. So first of all, racism, I think of it primarily as a societal system. It's premised on an ideology of inferiority. Yes, and it can lead to differential treatment by institutions and by individuals, discrimination. Yes, this inferiority, belief in inferiority, leads to a culture of stereotypes and prejudice that all have consequences. But the most important mechanism, I would argue, of racism are the structural or institutional components. And in the US context, residential segregation was a fundamental cause. By the way, the South Africans got residential segregation from looking at how well it worked in the United States. This is a point that is made by Duke University historian John Sell, who wrote a book about segregation. He called it the highest stage of white supremacy. And he showed that the framers of apartheid in the early 20th century looked across the Atlantic and saw how well segregation was working in the United States. And they said, brilliant, we can implement that in our country. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. It's beneath the radar screen of most politicians today, but it has powerful effects. Just to illustrate some of the effects quickly, these are two of America's most eminent sociologists, both here at Harvard, William Julius Wilson, Robert Sampson. They studied 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of Black communities. And research in the US indicates that segregation is, in fact, the central driver of racial ethnic differences in socioeconomic status. So David Cutler, an economist here at Harvard, using national data for the United States, shows statistically, if you could eliminate residential segregation, you would completely erase Black-white differences in income, in education, and in unemployment, and reduce Black-white differences in single motherhood by 2/3. All of those striking differences are linked to opportunity at the neighborhood level. We have data from the UK that finds the same groups that are disadvantaged on health are also overrepresented in the most deprived 10% of neighborhoods. So if it was equal, then you would see 10%, but you could see the Pakistani, Bangladeshi, Blacks from Africa, Arabs, Blacks from the Caribbean, and there is a gypsy traveler category that others here can elaborate on better than I can, also in this overrepresented group. So you see opportunities at the level of place seems to apply in different contexts. What these data illustrate is that the racial inequities in income and education and wealth that we see, they matter profoundly for life and health. They do not reflect a broken system. Instead, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. These inequities that we see are not acts of God or accidents. They illustrate the ways in which racism, through its upstream mechanisms, has produced a truly rigged system in the United States and in other countries. And then there is individual level discrimination. Martin Luther King said in 1967 that discrimination was a hellhound that gnawed at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as a truth in the society dominating them. And so if that's true, it's a hypothesis, does the interpersonal aspects of discrimination also matter for health? And the answer to that is overwhelmingly yes. This is one of the measures of discrimination I developed, not the only one, but the one that and doesn't capture all aspects of discrimination, but the one that has been used widely around the world. There are more than 450 published peer-reviewed papers documenting everyday discrimination adversely impacting health in countries around the world. And this doesn't capture all aspects of discrimination, just the little day-to-day indignities. Being treated with less courtesy and respect than others, receiving poorer service, people acting as if they think you are not smart, they're afraid of you, they think you are dishonest, or they are better than you are. Just to illustrate the impact, I'm drawing on the work of Tenny Lewis, was at Yale University, now at Emory. When she did this work, each line on this study is a different study that conducted, the different outcomes that she looked at. In all of these studies, she's just looking at everyday discrimination linked to high levels of inflammation, to coronary artery calcification, to higher blood pressure, pregnant women who report everyday discrimination, give birth to lower birth weight infants, elderly who report everyday discrimination, have more rapid declines in cognitive function over time. It's linked to poorer sleep. One study following a cohort of individuals over time, everyday discrimination is an independent predictor of premature death. So you can go across you see the broad range of outcomes, shorter telomere length, arterial stiffness, incident cardiovascular events, and even visceral fat. It was not linked to subcutaneous fat, but visceral fat, the deep internal fat within your organs that predict risk for cardiovascular disease. Everyday discrimination predicts higher levels. And the research is telling us that even these measures of discrimination understate, because there are hidden ways in which discrimination also has collateral negative consequences. One study of Black women in America found that over 70% were very concerned that their children might be harmed by the police. What does that do to their anxiety levels? Here is another study that I did with one of my former students. We linked a database with every police shooting in the United States over a 3-year period of time, and linked it to another database of the mental health of the population in every state. And we found that every police shooting of an unarmed Black person led to worse mental health, not just for the family and friends, but for the entire Black population in the state in which it occurred, and the elevated symptoms of mental health were elevated for 3 months. It was a specific effect. It wasn't every police shooting. It was only police shootings of an unarmed Black person. If the Black person was armed and shot by the police, there was no negative effect on population health. We think it's the perception that the person was unarmed, it was unjust and unfair, and importantly, it could happen to you. You're vulnerable because you don't have to be a criminal. You don't have to be doing something bad for this to happen to you. A third mechanism of this racism is racism embedded in the culture and stereotypes and stigma of society that leads to implicit and explicit biases. These negative stereotypes have adverse consequences. And in the United States, we just celebrated 2 weeks ago, I was a keynote speaker for a conference celebrating unequal treatment at 20. The unequal treatment report was an important report from the National Academy of Medicine published in 2003, documented for the first time that across virtually every therapeutic intervention, from the most simple to the most complicated, Blacks and other minorities received poorer quality care. It was not about access to care, given access, poorer quality care across virtually every domain of medicine. Just to give you an illustration of the persistence of this pattern, one study published in 2020 of 1.8 million hospital births in Florida between 1992 and 2015, when cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. That disparity is cut in half when Black babies are cared for by a Black doctor. Striking differences, the study doesn't tell us what drives it, but a striking pattern of difference. So what can we do about all these inequities in health? Well, we need to build more health into the delivery of medical care. By that, I mean, we need to ensure access to care for all. That's something we do not experience in the United States, but there is evidence that improving access, high quality access to care for all can address some, not all, disparities in health. We also need to diversify the health workforce to meet the needs of all patients so that patients can see individuals they can identify with. And there is evidence that I don't have time to go into that shows that leads to greater engagement, improvement in medical care. We also need to provide care that addresses the social context. as the World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? So we need to think of how we can build within the delivery of healthcare, addressing the social needs that patients have. Strategy number 2, we need to identify and supportive and protective factors and resilience resources that can make a difference. People are suffering now, and we need to help them relieve some of their pain. There's research documenting that the quality of social ties can reduce some of the negative effects of exposure to racism, that among First Nations communities, engaging young people in advocacy, protest, and understanding and supporting their culture can improve their mental health and reduce some of the negative effects. There's some work in the US that suggests that religious involvement and engagement can also reduce some of the negative effects of exposure to racism. And number 3, importantly, we need to create what I call communities of opportunity to minimize, neutralize, and dismantle the systems of inequality and racism that create inequities in health in the first place. That means we need to enrich the quality of neighborhood environments, increase economic development in poor areas, improve in housing quality and the safety of neighborhood environments. Importantly, there are a broad range of factors. This is a review paper I did with Lisa Cooper, summarizing the research, documenting all of these strategies, like reducing childhood poverty, enhancing income and employment. All of these have striking consequences for improving health and reducing inequities in health. So what's holding us back? What are some of the barriers we have to address? This is a long quotation, but it's an important one. Martin Luther King said back in 1967 that the majority of white Americans consider themselves sincerely committed to justice to the Negro. They believe that American society is essentially hospitable to fair play and to steady growth toward a middle-class utopia embodying racial harmony. But unfortunately, this is a fantasy of self-deception and comfortable vanity. Overwhelmingly, America is still struggling with irresolution and contradictions. It has been sincere and even ardent in welcoming some change, but too quickly, apathy and disinterest rise to the surface when the next logical steps are to be taken. Profound words. We face 3 challenges, I would argue. We need to raise awareness levels that these inequities exist. Most people don't know they exist. We need to develop the political will to address them, and we need to build empathy so that we feel the pain and the suffering of others and decide that this is unacceptable and we want to do something about it. I leave you with these words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. Racism is a global edifice adversely impacting the health of populations around the world, and we need to work together to restructure that edifice. Thank you so very much.
Thank you very much, Professor Williams, for that really masterful overview. In a short time, you just really taught us so much with such powerful evidence and such extraordinarily eloquent work. So thank you for that. I'm now delighted to welcome Alexandra Oprea. Where's Alexandra? Oh, right there. To be our discussant. Alexandra is actually someone who's been at our conference before. She's a Romanian Romani attorney and an activist. And again, I'm not going to go through her whole bio, which you all have seen, but she has been a fierce and really indomitable advocate of the rights and the needs and the entitlements denied Romani women. And as her bio says, she has appropriated and used and learned from the work of Kimberly Crenshaw in an important way in taking it into the Romani context. So Alexandra, thank you so much for joining us today, and we look forward to your comments.
Thank you so much for having me. And so before I get to that, thank you so much, Dr. Williams, for your thought-provoking presentation. I wanted you to sit there so I can get your reaction on a couple of slides that are going to be equally provoking, thought-provoking. So my comments are basically going to talk more about our ability to have conferences like these and to talk about these issues in the first place. And they predominantly center on the United States because that is where I've grown up and that is where I fight for racial justice now. Although my work has traveled, in my earlier work from 20 years ago, traveled to Europe where it made a significant impact. So in May of 2020, we had this racial reckoning after the murder of George Floyd by law enforcement, and political protests swept the nation. Folks were calling for racial justice, for structural reform. There were a growing number of young people taking to the streets and questioning their government, asking how something like this could happen and keep happening. Tyree Nichols, Breonna Taylor, Eric Garner can keep happening over and over in a multiracial democracy, right? And that is not living up to its ideals. So when we had that reckoning, we quickly faced a backlash. And I'm sure you've heard of the various forms this backlash has taken. We've had attacks on critical race theory and what has been packaged as critical race theory. Now, I studied critical race theory at UCLA School of Law, and while I was at Columbia with Kim. And to see it in the news in that way, to see it elevated into discourse as something negative was really shocking and really hurtful, especially because my earlier work that was so influential in the Roma rights movement and in helping to craft a gendered Roma rights movement relied on critical race theory, on intersectionality that Kimberly Crenshaw coined in 1989. And so many movements have looked to critical race theory. When you're talking about structural racism, that's critical race theory. When you're talking about institutionalized racism, when you're talking about the 3 scales that Dr. Williams described, that's part of critical race theory. So they've demonized and rendered toxic this theory that's been useful to helping us identify the conditions that lead to our premature death, the conditions that basically render us vulnerable. So the backlash has taken, various forms. There have been bans against books, Maya Angelou's books, Toni Morrison, The Diary of Anne Frank, also been banned. There are thousands of banned books, thousands. At least 21 or so states have banned what has been packaged as critical race theory. Basically, if we didn't have critical race theory, we wouldn't be able to really have this conference. A lot of that work came out of the civil rights movement, came out of legal scholars who were just trying to produce a racial literacy, just trying to identify how race is actually leading to these negative outcomes and premature deaths and infant mortality, higher infant mortality rates, maternal mortality rates, higher rates of breast cancer, all of these inequities. So I kind of wanted to use my platform today to sound the alarm, because the attacks on critical race theory are not just about critical race theory in academia. The book bans are not just, K through 12, although those should be alarming, right? It's seeping into every aspect of our lives. They've attacked ESG, environmental social governance initiatives in investing. They are now coming for the medical arena. So there have been numerous, attacks on quote unquote woke education. What does woke really mean? It just means racial consciousness. It just means paying attention to structural racism, paying attention to the things that Dr. Williams described, to implicit bias, to the difference in treatment. Why were so many during the pandemic, so many Black people turned away from hospitals? Why did Dr. Susan Moore, if you're familiar with her, why was she treated like a drug addict when she was asking for medication that would save her life? And so I kind of wanted to get Dr. Williams's, for my question portion, get Dr. Williams's take and have him opine on how this resonates with the work that he was doing in the 1990s. Because from my understanding, in the 1990s, you set out on a mission. There was an understanding that racism had some sort of an impact on health. And you set out on a mission to document exactly how this was happening in the various ways. how does this, so my first question to you is, how does this resonate with the work you were doing? Did you ever imagine that 30 years later, people would be questioning the even the existence of, basically, why are we talking about race in a medical classroom? And they would be attacking this work on such a large scale. And there's Harvard Medical School. And so there's this notion that those of us who are talking about race and pointing to structural inequalities are the ones doing the indoctrination, that we are the ones committing the oppression, right? Victimizing. They've been in these articles, they say there's a crusade against medical professionals. They posit it as sort of being in competition with merit, as though you're not going to learn how to, treat someone's kidney disease if you learn about implicit bias. These are the kinds of things that were being derided in the articles. Requirements to learn implicit bias, requirements to, I think there were some applications that asked students, quote, to describe their understanding of race and its relationship to inequities in healthcare. And that was just an abomination, right? The idea that students should even have that on their radar is an abomination. And this may seem like it's just a Tucker Carlson thing, it's just a fringe thing, but that's what we thought 2 years ago when Rufo came for critical race theory, when we had the executive order was repealed. Then we saw numerous copycat legislations on the state level. There are books being banned that we don't even know about because they're happening at the school board levels, right? So there's this just full scale attack on our ability to name our oppressions, to diagnose our conditions, to basically talk about our lived realities. And it's coming into the healthcare field. So essentially, I wanted to posit those images and that rhetoric against what we know and against what Dr. Williams has described, mostly the disparities in treatment during COVID-19, the case of Susan Moore, who was a doctor and who could, basically diagnose her own conditions, and she was not taken seriously. She was treated like a drug addict. She was told she could go home. And I wanted to uplift these stories because something similar is going on in Europe with Roma as well. It's just less documented. So, and of course we have long COVID to worry about, right? So this is far from over. And there's a recent report I also wanted to highlight. So knowing all that, all these attacks on how we don't need to talk about race, we don't need intersectionality in medicine, we don't need to pay attention to these things, they're basically irrelevant to the practice of medicine. When we're looking at Black maternal mortality rates, I think Black women die at 3 times the rate of white women. And this was a landmark study. I think one of the reasons it was a large study that basically showed it's not about class, or not only about class, because they looked at women who had the same incomes, and Black women were still, I think, twice as likely to die. So I wanted to uplift those stories and so the first question to you, in case you didn't catch it because I rambled, was how these attacks, right, resonate with your experiences. And did you ever imagine that we would be at a place where we're even questioning the relevance of race, right? Wait, should I? Okay. But there are more slides I want you to see. It's okay. Okay. No, those were good enough. All right. Okay. So that is my first question. The second question is, I wanted to talk a little bit about intersectionality. And you mentioned in some of your studies that is a limitation, that we haven't had much progress in terms of intersectionality and looking at intersectional vulnerabilities. So I wanted to uplift one story that really struck me during the pandemic. And it's the story of a 9-month pregnant Romani woman. A lot of the Roma here probably know the story, who died outside the hospital. I think, actually, no, they brought her in, who died after seeking medical care 3 separate times. She was 37 years old. She came to the hospital when her water broke. She was turned away. She was told that she's not ready to deliver. She went back a couple of days later with severe pain, intense abnormal pain, showing signs of bleeding and infection. She was sent home. Second time. Then the next day, returned with worsened pain and was told by a different doctor, not yet ready to give birth. She was 9 months pregnant, bleeding and infection and abnormal pain. Turned away 3 times, right? And this is Macedonia. On the 31st, she arrived at the hospital, and you're thinking, great, wonderful. She's finally going to get some care, right? She arrived there at 1 p.m. because it was during the pandemic, and she had a fever because she had an infection because she wasn't treated. She was not admitted into the hospital. She was literally left to wait outside, not treated until 7:30 p.m. And she died. And that experience is just one that, you know, I'm picking to highlight. There's so many that are unreported. There's so many that we don't hear about. Roma are erased across the board, from statistics even, right? You see statistics, and this happens in the United States too. They'll do it black, white, various, you know, races, and then they'll do gender, women and men. And they won't disaggregate by race and gender oftentimes, and women of color slip between the cracks. So this is just one of the stories that I think really exemplifies the intersectional vulnerabilities that we see. I think that one of the most dangerous times for women of color in the US and in Europe for Roma women is when they're pregnant. We see the segregated maternity wards. We see the segregated, you know, medical apartheid, quite literally, where we're sent into different rooms. And in the United States, you see a different type of medical apartheid, right? With the difference in treatment and the lack of treatment and the lack of pain management. So I wanted to get your take on, I wanted to get your take on what you think some of the barriers are to addressing intersectional vulnerabilities, and what you think we are left with if we erase critical race theory like arguments and the rhetoric of racism and structural racism. What we're left with, is it these types of personal responsibility rhetoric, where we remember the Surgeon General telling you to do it for Big Mama, stop drinking alcohol, you know, during COVID, and things like this? Well, why don't segregated Roma do more for their health? Are we left with these types of explanations once we erase the theories that have helped us explain these inequities? Thank you.
Sure. Thank you so much for the data you provided us and the glimpses you are giving us of the challenges that we face in the US and elsewhere. Power never concedes power without a struggle. And so for every step forward that has been made, there has always been pushback. Many persons in the US date the Trump presidency with a lot of pushback that has been taking place, but it's late to date it with Trump. There was an annual review of sociology paper that showed the impact of Obama's election on whites in the United States. That a large proportion of whites said they were troubled that a black man was in the White House. And there were organizations and groups that were developed in response to Obama's election. Trump capitalized on that resentment. He didn't create it. It was created actually by Obama's election, and is well documented in the scientific research. And so, did I expect that these things would happen? Not really. I have on the academic front, this just when I started doing work on racism, I could count the 10 people in the world who were doing work on racism. And I can't keep up with the literature now. So it's wonderful that there's so much taking place. And yes, it wasn't that the work was welcomed in those early days. One comment I got from the review of a scientific, one of my papers submitted was, the term racism does not belong in a scientific paper. The review went on to explain racism is an ideological concept that cannot be measured. And that was the way in which we functioned in those early days and tried to push back against that. So we have made progress on the academic front, but there has always been pushback. And you're correct, there's enormous pushback. It is a source of stress for me because I'm on Christopher Rufo. You mentioned his name. He is the single driver. I get an email from him almost every day. I don't know how I got on his mailing list, but I'm on it. No, but it lays out the strategy. It tells you what's happening, the op-ed coming out in the Wall Street Journal tomorrow. It has a sample of the model bill to ban critical race theory that is being sent to their operatives in every state. So it does show you the whole strategy, but it is quite disturbing to see what's happening, and it's quite disturbing to see how quickly it took place in Florida and Texas, and so many other states are implementing it. So yes, we are living in a difficult time in which the issues I raised at the end, we need to be much more strategic than we are. Persons who want to be successful, who want to see it differently. I talk about the need for those of us in the health field to work more closely with communication experts and to work more closely with political scientists, because we need to identify how to best communicate. There are too many scholars I know who are just concerned about getting the facts right and then downloading the facts, but not really communicating with the mass public so that we can build a movement and that we can raise awareness levels for people to say this is unacceptable. And importantly, to build the empathy we need that it would take to trigger the political will and the feeling that we have to do something to change the narrative and we can do better than we're currently doing. So I do think we are facing an enormous challenge in this moment.
Thank you so much, Professor Williams. So I think we have a minute or two if there are people who'd like to actually raise a question or make a comment at this juncture. Please raise your hands, and we'd be delighted to hear from you. We will be looking at these issues, for the next few hours. So if you don't have the question quite formulated yet, there'll be other opportunities. But would anybody like to raise a question? No. Okay. Well, oh yeah, there we have one. Okay. Yeah, please just introduce yourself. Go to the mic if you don't mind so that everybody can hear you.
Miriam Asmus from the U.S. Department of State. Anything that you see happening on the federal government level that is helpful or harmful, and any thoughts about, given that level is shifts with different administrations, things that could be embarked on now that could be helpful going forward?
That's a really good question. Within the U.S. context, the federal government is an enormous bully pulpit that can set the tone, that can frame the issues. States have the rights to set laws at their local level. So there's only so much that can be done for some of the legislation. But I think more could be done than is being done. Silence allows one narrative to dominate the airwaves, and there isn't much of a counter narrative available. And certainly at the federal level, there could be counter narratives. There could be responses to the things that are so wrong and so inaccurate, and there's such a legacy of untruths on the context of some of those who attack. So I'll give you an complete example of why Harvard Medical School was being criticized. There was a study done that looked at 10 years of data for persons admitted to Brigham and Women's Hospital, one of the Harvard-affiliated hospitals a few blocks from where we are, that documented that Blacks and Hispanics admitted with heart failure were less likely to be admitted to the cardiology unit and more likely to admitted to the general medical service, and their outcomes were worse than the whites who were admitted to the cardiology unit. And they said they will put a flag in the record when a Black and Hispanic person is admitted, just to remind people we want to ensure that they get the best care. That has been attacked by the right-wing media in the United States as making race the thing that drives medical care and as such a terrible disaster and such a disgrace. So it's an example of when there are these narratives that are being generated, and many people only hear the one side that is loud. And we need to think of how the bully pulpit could be used to tell the truth and to provide a rational explanation to individuals. Because if there's only one story, there's only one channel, that's all that people are hearing.
Professor Lewis, I wonder if I could just follow up with a last question. So I know we have some doctors in the room who I'm sure would love to, correct some of these defects in the hospitals and practices they work in. So, the picture you present is pretty overwhelming. It goes from racial segregation residentially to wealth gaps. It's a kind of overwhelming picture. So do you have any specific suggestions for young medical professionals? I mean, this thing of, for example, flagging, I can see one of our medical colleagues who I know was part of that effort, which got criticized. Are there specific practices that you think have worked well, that are useful for young doctors who are trying to ride against the stream? I know you're an academic and you're not a doctor, but maybe it's an unfair question, but I do think that given that we have people also from Europe who are learning from you, this would be a very interesting contribution if you have anything to add.
I would add two things quickly. One is the most widely used strategy to address issues of racial ethnic differences and in quality of care and implicit bias in the medical institutions, as well as in corporate America, is to conduct implicit bias trainings. There is overwhelming scientific evidence. There's one review of over 900 studies of implicit bias training. Implicit bias training, as currently conducted, do not reduce implicit bias. They are useful in raising awareness that it exists, but it does not change behavior. I like to point, and there's no question that's true. The evidence is overwhelming. I like to point people to the Divine solution. Professor Patricia Devine from the University of Wisconsin-Madison has developed an implicit bias program that is effective in reducing implicit bias. It's a 12-week program with me for 2 hours a week for 12 weeks, where they practice exercises, where they have homework exercises. So it takes more than a 1 hour or 2 hour workshop to change behavior. That program is effective in reducing implicit bias, and the effects are still evident 3 months later, which is the longest has been shown in an implicit bias test. So Patricia Devine, University of DEVINE, University of Wisconsin-Madison is an example of what we need to do more of. The second thing, there was a study, I don't have the citation for it right now, but there's a study that was done in San Francisco that found among patients with HIV/AIDS that there were racial disparities in the patients getting the appropriate treatment, in the treatment working, and in the patients taking the treatment as recommended. And so there were these three inequities that existed. The researchers reanalyzed their data. They had administered to the providers a cultural competence scale, and they found that those providers who were high on cultural competence, regardless of their racial ethnic background, there were no racial disparities among their patients. What did it mean to be high in cultural competence? It was providers who agreed that family and friends was important to health as doctors. Providers who agreed that they asked their patients what they think is the cause of their illness. Providers who said they engaged their patients in making decisions about their healthcare. Just examples of the question. It was what emerges from that scale of high in cultural competence is providers who who respected their patients, who engaged with them, who involved them in care, and under those conditions, irrespective of the race of the provider, there were in fact no inequities in health. So again, that kind of engagement is what seems to be effective.
Thank you so much. Those are amazing examples. So please join me in thanking this wonderful panel.